Well, hello everyone. This lecture is intended as part of class 1 that we had last week. It follows up on the items that we discussed, and it also incorporates things that have been addressed in the chapter and the text. And of course, in addition to the explanations and the kind of the clarifications of things in the text, there will be additional material and additional, kind of sources and explanations, basically to kind of reiterate and to add to what we have discussed. So this way, when we come to discuss the material next week, you should have this background already in place. So first, let's go again over some of the terminology. We know that the term assessment is a wider term that is used basically to include the entire process of testing, pre-testing and planning, and basically the aspect of sitting with the patient or the client and administering a particular test and interpreting and the entire thing. So it's a wider term, and the term evaluation it is under it, but technically, however, in general terms, when I speak with my colleagues who are speech language pathologists, for example, we do not typically distinguish between assessment and an evaluation. We do not get stuck on the technical, things. So, an evaluation is the same to us as assessment in terms of what to administer. If someone says, I would like to refer this person, for further assessment, or to have an assessment, a speech language assessment, or a speech language evaluation, the two terms are synonymous. Diagnosis is based on all the results and all after you administer testing and analyze and obtain data and information, then you make your professional judgment. It's a judgment statement based on all that you have collected, all the data and information that has been collected, and then you now make a determination as to if a patient or a person qualifies or shows symptoms and characteristics that are consistent with a particular disorder or we call them disorders, communication disorders. Sometimes, like in the school systems, they might call them disabilities based on, what state you are in. So, diagnosis is the statement that you make pertaining to specifying a particular disorder. So now you make a diagnosis only when there is evidence that a particular disorder exists. So the diagnosis is basically involves a label that you give, that this person has a language disorder or a speech disorder. Again, the diagnosis confirms the existence of the disorder or the problem that had been suspected before when the referral was initially made. And typically a diagnosis also involves kind of the identification of the features and the symptoms of that particular disorder. And in many cases, especially like say in voice disorders, you are able to know the etiology. Language disorders you could, but in some cases it is vague and you might not be able to find out the exact cause of a language disorder. It is even more difficult to identify the cause of a speech sound disorder. So the purposes of the assessment, why do you evaluate anyone. We evaluate someone when we suspect that this person has some kind of either a speech, a language, or a swallowing disorder. And we discussed in class the differences between, like in clinical terms, what is a speech disorder? So we said a speech disorder is a disorder in three primary areas, and that typically has to do, speech disorders have to do with the motor production of speech. So number one, voice disorders. They fall under speech. And two, speech sound disorders. They fall under speech disorders. And number three, fluency disorders. Fluency disorders mean disorders that disrupt the fluency and the natural flow and rhythm of speech. And they include stuttering. Stuttering is an officially recognized diagnosis, and it is listed in the DSM and elsewhere. However, cluttering disorder is not an official disorder that you will find a code for in the DSM or ICD-9 International Classification of Disease, ICD 11, I think, the most recent one. So it is, this kind of disorder has been described and by many clinicians over the past maybe 15 years. However, again, it has not been officially recognized. But when we evaluate, we look at the cluttering and stuttering, if you know which one it is. And each one has characteristics and, signs and symptoms. So then we discussed, we spoke about language disorders. We said there's one label that is generally called language disorder. And under this, you are going to look at areas when you do the evaluation. You look at receptive language skills, and then you look at expressive language skills. So receptive is what you have here. Expressive is what you are able to, share in different modalities. Modalities like writing, modalities like signing, modalities like verbal expression. All of these are forms of expression, forms of expressive language. And in addition to the expressive language component, of course, the actual language component, we look at the non-linguistic components that go with the language that would make language interpreted and understood in different ways. For example, gestures, facial expressions, body language, tone of voice. These are non-linguistic aspects. However, they are critical to the understanding of the content of language. So these fall under expressive language. Then we have also, we spoke about having, in terms of language disorders, there's another category that falls under language disorders that's called cognitive communication disorders. And these have to do with problems that are based on brain mechanisms that disrupt the natural processing of language, the natural expression of language. Let's say traumatic brain injury. The traumatic brain injury, it comes in various forms, but some of these kinds of traumatic brain injuries could disrupt communication. They could affect language comprehension, language planning, and language expression in various ways and to various levels. So these fall under cognitive communication disorders. For example, the dementias, and so on. You have one entire course that focuses on cognitive communication disorders. in the grad program. So these are they are in the realm of language disorders. And then we have the other category, which I mentioned previously. It was part of language disorders, and that is social communication disorder. And again, technically, it, you know, when you look at it and describe it, you are looking at language, how language is used and so on. But the focus is on use of language for social means, for social purposes, as opposed to, say, academic or stuff like that. But it is using language to achieve social goals, making friends, interacting with people, communicating and facilitating communication with the community. And we will be discussing social communication and social communication disorder later in the course. So now, again, when we speak about the purpose of assessment, we look at all of these areas, and in addition to swallowing, of course, all these areas that I have just discussed, the areas of speech, the areas of language, and the areas of feeding and swallowing. Then, initially, someone, or you yourself might notice that someone is not doing well in one of these areas. So what you do is, typically someone refers a person to you, either in a hospital. In a hospital, they call them patients. In clinical practices, sometimes they call them clients. In medical practices, they call them patients as well. So in school systems, they call them students. So you have these terms, different, but it's the same person that we are speaking about. So someone comes in saying, this person, say my wife, for example, had a stroke and she's having difficulty with this and that, and would like to have an evaluation for her. Or a teacher comes to you and says, I feel like, this child is not using language. There's something wrong with the language of this child in terms of speaking or this and that, or comprehension and so on. They come with concerns. Sorry. And these concerns basically highlight the areas that you need to focus on when you do your evaluation. So then your purpose now is to determine if indeed the suspected disability or the suspected problems are founded in reality, like if the patient really has these problems, and to identify what kind of disorder these problems indicate or show or are part of. So you determine if the person has a problem, if the person has a disorder or does not have a disorder. So it is either way, to either exclude or to confirm the presence of a disability. Then, in addition to this, someone might also be confirmed, like, this person is already diagnosed, say 3 years ago, with a language disorder. Now, that person is referred to you for a re-evaluation. This is why I mentioned it is important to know or to notice if this is an initial eval or a re-eval. So, in this case, why do you do testing? You want to identify, you want to re-examine, you want to re-evaluate the person to find out if he or she is still eligible for services, if he or she is still present with the same disorder. And also, one big piece, of course, why we do testing, of course, in many contexts, is to determine if someone is eligible for services. Health insurances are going to require testing so that you confirm that this person actually has a disability that requires to be addressed. And school systems require evaluations to confirm if the person is eligible to receive special education services in the area of speech and language and swallowing. So then you can also administer testing. Let's say you do a test, administer a particular test, and then you work with the patient. There's a lot of progress, but you want to be objective and to show exactly with evidence that this is real progress, and to determine how much of a progress you have, the patient has accomplished. So determining the level of need, for example, if to what extent the person needs, for example, services. Do they require one time a week, 60 minutes, or maybe one time a week, 45 minutes? Do they require 2 times a week, 3 times a week, 4 times a week? Whatever it is, that is based on the evaluation that you do, because when you identify the disability, you also identify the severity. Is it a mild problem? Is it a moderate problem? Is it a severe problem? It doesn't end here. You also do, is it a mild to moderate problem, or is it a moderate to severe problem? So how many levels of the rating of the disability or the disorder do we have now? So one, the problem could be mild. That is based on your interpretation of your results. The problem could be moderate. It could be severe, or it could be mild to moderate, or it could be moderate to severe. 5 ratings. And that's very important. And that is based on judgment. That is based on your understanding of how the test interpretation goes, and exactly what the test manual tells you in terms of what is average, what is above or below average. So based on that level, based on the severity, then you are going to determine the level of need. If someone basically has a mild problem, you might say, well, I would be comfortable seeing the patient once a week, 30 minutes per session. Duration means how many minutes, how long is the session. And then frequency means how many times per week, or how many times per month, or how many. So frequency is like how many times do you do the sessions. Duration is how long the session is, and the level of need is, how many sessions, for example, the person requires, or based on the severity, obviously a moderate level is going to require more services than a mild case, and a severe is going to require more than either one, or than both of them. So again, you administer testing initially, you get the information that is called a baseline. That means where the patient was when he or she came to you initially with that concern. Then you do intervention and all of this, and then you go back and retest. The purpose of retesting is to take these scores and compare them to the previous scores, and the difference is going to determine the level of progress that the person made. And based on that, in many cases, the patient might come average the second time that you test him or her, and that means they do not qualify. They don't have the disability anymore. They do not have the communication disorder anymore. And so based on that, that scores that you get could also give you evidence to terminate services for that particular patient. Now, there is that making a diagnosis and making a differential diagnosis, or the process of making a differential diagnosis. A diagnosis by itself is made when there is one single problem that is identified. Let's say someone comes to you and with a stuttering situation, and the person speaks like this. What do you call it? The thing that you use to start the car, the key. So, and when you go and want to what do you call it? Start the engine. So what I am doing here, you notice when you look at the fluency of that segment that I did, that there were some sound repetitions. These are signs. You could say, oh, sounds repetitions are part of stuttering. But also, like all of these things are disfluencies, DYS. Disfluencies. They are fluency problems that disrupt the flow of speech. However, you have two situations now. Number one, the sound repetitions themselves are an integral part, a core component of stuttering disorder. The one that grows beyond child. I mean, the child is born with it, and the child keeps developing, and the problem doesn't go away. The classical stuttering disorder. And then the second part is these whole words and these what we call gap fillers. These things don't mean anything, but the person just inserts there to buy time until they think and plan what they want to say. So that is not, even though they accompany stuttering, in many cases, that is not part of the actual stuttering. And all of us, in any situation, when you observe any speaker, we are going to insert some of these one time or another. So the idea, of a perfectly fluent speech, I don't know if it exists. So, but however, when it exceeds a certain limit, estimated about 10%, then it becomes disruptive and it becomes part of a disorder. So what I am saying here is that we have two situations now. And you ask the question, is that a stuttering disorder, a true stuttering disorder, or is it a cognitively based disfluency or a cognitively based problem that is causing disruption in the fluency? So, for example, is the person an adult? And if the person is an adult, when did he or she start that problem? So in that case, it is not clear to you. You cannot just go and say, oh, stuttering disorder, and then you describe and say the patient did this and that, and it is not enough. You cannot do that. What needs to be done in that case is to differentiate the different sets of symptoms or features and separate them and explore each one of them. So the repetitions of, words and the delays in time and the gap fillers, like these are not the typical components of the classical stuttering disorder that will tell you that if someone has them, they must have a stuttering disorder. They are fluency problems, obviously, but you want to go and explore, do some testing in memory areas, in attention areas, and explore and see if the person has a memory disorder. So if the person has a memory disorder and they have very poor memory, then that doesn't qualify that person, you don't call it a stuttering disorder. You call it maybe, a problem that is causing disfluency or disrupting the flow of speech, but it wouldn't qualify as a stuttering disorder. So another example is, let's say someone comes to you and says this person is having a problem with comprehension. Now we know that comprehension problems can be caused by any number of things. There are some comprehension problems that are specifically caused by language problems. For example, someone doesn't have the vocabulary. They do not have a good grammatical rules here. Obviously, they will have tremendous difficulties comprehending what is being said. And if that's the only problem now, and there's no indication of other problems, then you say, well, I'm going to do testing, the vocabulary score is low, and then you find out that the person's grammatical constructions and grammatical rules here are below average, and then you say, that basically confirms it. Now, when in that case, the diagnosis is clear and you don't worry, it's a single situation and there are no suspected disorders that could be confused with the language disorder that you have identified. But if someone comes and says, this child has difficulty understanding when she reads, she cannot comprehend. And then when I tell her, say something to her, she completely distorts it. I said, I want a chair. And then she said, what do you mean you want a chair? So chair could be heard as a share. Log could be heard as dog. What the person, what do you say to the person? Goes in here and somehow doesn't translate into what you actually said. And the patient understands it as a totally different thing. So in that case, it isn't just merely a vocabulary problem. It is not merely just a grammatical or whatever. You have two situations or even two situations and say, well, what could cause these kinds of problems? And then you look at the auditory processing disorder as an option. And then also you look at the language disorder as an option. You have two suspected disorders now, and you want to explore each one of them and then exclude the one that is not there or confirm that both of them may exist. And in some cases, yeah. So a differential diagnosis is performed when more than one disorder are suspected. So sometimes it is three areas, and you wonder, is it a language disorder? Is it an attention disorder? Is it an auditory processing disorder? These three are commonly confused together with each other. And is it a memory disorder? And so you have to constantly be aware that of the different kinds of features of different disorders, so that when you make a diagnosis, that diagnosis is correct, that diagnosis is accurate. You don't want to do the testing and then you say, oh, this person has this disorder, and someone else does the testing, and then they get a different result, and they say, no, there's no evidence of that disorder, but there's evidence of that instead. In terms of screening and evaluations, and strictly I'm speaking about screening in speech-language pathology. The reason is screening in different fields is kind of treated and looked at in a different way. Like someone has a mammogram. That's a kind of a screening. And if that shows, the screening shows, for example, a particular lump or something, it could actually be used as, as a way to make a diagnosis. They do a biopsy after, and then, the person has breast cancer, or the person doesn't have. So it begins with that screening. However, in speech language pathology, a screening is an informal or a formal, kind of assessment. However, it is brief. 5 minutes, maybe 10 minutes. You could do it by looking at the person just, for 5 minutes, interacting for 5 minutes or 10 minutes, and then making some kind of opinion, judgment based on what you have seen or what you have heard. Now, why do we do screenings? The purpose is not to make a diagnosis. You cannot, in speech and language pathology, you cannot make a diagnosis based on a screening, based on 10 minutes or 5 minutes that you see a patient or someone and they say, they have this disorder, let's go and start therapy, or they do not have the disorder, and send them away. So the idea is you do a screening in order to confirm that the concerns that you or someone else has are kind of valid, and that the most important part is to determine if a full speech language evaluation is required. And I mentioned to you in class that in my own experience, based on 12 years working in the school system, out of every 10 cases that I evaluated, about 8 or sometimes in some years 9 cases did not qualify for language disorders. So in many of these cases, they actually had different problems, and I made referrals, to the specialists to explore these problems further and to see if, there are other problems other than language. But in some cases, the person doesn't have any, the concerns and so on do not amount to a full disorder. And in some cases, maybe the person wasn't given a chance to actually learn the skills in it like everyone else. So the idea, that is important. The idea of a disorder now is that when you give everyone, like say you have 10 children growing up in, say, a city, and you give, let's say they live in different houses and families in different parts of the city. However, maybe they are the same age, they go to the same school. Or may not go to the same school, but do they have exactly the same level of support? Are they receiving the same level of care? Do they have the same environment? Do they have all the opportunities that are needed in order for them to develop language and speech in a normal way, in a typical way? If that is the case, and then you go and test one of them, then they should exhibit similar results. Their performance should be similar to the normal, what we call normal or typical average performance. However, there are cases where there is child abuse or child neglect, when the parents do not interact enough with the child, they do not read enough with the child, they might not even read at all. The child is not going to, is not benefit. The parents are not involved too much in the school. The school doesn't provide the resources that are needed, and a whole different, things that could go together to prevent the child from having the experiences, the normal experiences that other children his or her age should have in order to develop the required skills. So in that case, the child has the intellectual abilities and everything. However, he or she were not given the chance to learn the skills that you are evaluating them on or in. So in that case, that wouldn't be a disorder. You identify that the person has a decreased language skills or this and that. But when you give them a few strategies, they do really, really well. Even in the same session, they understand it and they give you the right answer. So that wouldn't qualify as a disorder. A disorder is a problem that, or in other words, when you give the individual everything that you give to his or her peers in terms of instruction, in terms of resources, in terms of time and interactions, and everything is in place, and that despite all of this, the person doesn't develop the skill as, the typical peers do. And in that case, for example, the testing scores are going to show a true disorder. It means, yes, you had the opportunities, but you are not performing up to the level of your typical peers, typically developing peers. So again, we cannot make a diagnosis based only on a screening. The screening confirms to us that there is a need to do a full evaluation, and the purpose of the screening basically is to save resources and to also catch cases quickly so that they do not they are not deprived of services when they need the services, and saving resources. Like I said, if I work and I have 50 or 60 children on my caseload, and I spend all this time testing so many people, I wouldn't have enough time in my schedule to actually provide therapy for the ones who need it. So the screening makes us, or increases our suspicion that there is a problem, that we need to spend the 2 or 3 or 4 hours that we spend in doing the evaluation. So components of the assessment, and what does the assessment consist of? Number one, it involves collecting information about the patient or about the client before you see him or her. You get a case history. You interview the parents or the caregivers, the husband or the wife, or whoever has an intimate knowledge, has a good knowledge of the person's performance. And then you interview the patient at the beginning of your evaluation. So you ask, maybe before you start testing and stuff, you start asking him or her some simple questions like, tell me, how do you like school? Or do you, what kind of, for example, college do you go to? Or have you ever experienced or what kind of sports do you play? Have you ever experienced hits to the head, or did you fall at any point in time? Were you riding a bicycle? Do you ride a bicycle, for example? So asking questions to explore different possibilities that can help you interpret the results that you get. So the interviews could be phone interviews. They could be face-to-face interviews. You could interview, say, teachers for a few minutes, or a spouse, or a close relative, or a foster parent, or a parent. And then the patient, like I said, at the beginning of obviously, sometimes you have very little children, 2 years old or even 1 year old. You're not going to be doing an interview with them, but you'll interview the caregiver, you interview the parent. And then there are questionnaires that you send to parents, to teachers, to anyone who knows the child's performance closely, and they complete these questionnaires and send them to you either by email or send them to you by hard copy, whatever works. And then you do your testing. So now, collecting the information involves case history, interviewing, and questionnaires. And then the actual testing that you do. Before that, I needed you to add here, after the questionnaires, to add clinical observations. So the clinical observations, yes, you begin collecting information at the beginning when you see as soon as you see the patient, you write clinical observations. But these clinical observations, they continue through the entire assessment. And basically, the end of that is notes that you take. Or the patient did this, the patient did that, the patient said that, the patient, and when did the patient say it? For example, you are asking the patient to repeat sentences. And the first set of sentences are 5 words. So 5 words, the patient did fine. There's no indication. You don't even have to write notes. And then you come to an item where you start 7 words in the sentence. And immediately the patient starts forgetting, and having difficulty completing that. So you write the behavior, like she took a longer time. She got distracted. She started with the first word and then she came to the last word immediately. So you write an indication about the behavior, physical behavior or verbal behavior, hesitations, and so on. Someone, when you asked a question, they were embarrassed. They looked down. They didn't look you in the eye. They looked away. When they heard the sound, they got distracted. There was a bug on the wall, and they just, were very scared, and so on. Anything that is going to have an effect on the interpretation of the scores that can help you make a diagnosis. And then the testing part. That part is when you ask the patient the questions and say, like, questions about the skills. So I happen to have a protocol here for one of the tests. This is from the social language development test, the adolescent version. And it says one of the questions is, pretend you are this girl. How are you thinking? What are you thinking? And of course, there's a picture that goes with that. And the girl is showing some kind of attitude visually, and she's using a certain kind of body language that goes with a particular state of mind. Like someone seems confused, or someone seems concerned or angry. So look, pretend you are this picture. The girl in this picture. What are you thinking? So that is one item, for example. So you administer the items that assess, that measure the specific language or specific speech skills that you are evaluating. So that is testing. And testing, it includes typically 2 components. A formal part that involves tests that were produced by companies, like the one that we used in the class last time, the PBBT4. So that is a formal test. You cannot modify it. You cannot just, kind of make any changes. You give it as based on the instructions that were given by the developers of that test. So any kind of test like this that doesn't give you much flexibility and stuff, that is called a formal test. And then there are informal. You can call them informal instruments or informal measures. So the informal ones are things that you can come up with, things that you might get from other resources. The informal items could be, part of that could be, for example, a language sample when you have someone describe some pictures, or you have them tell you a story and you write down, take a language sample, and then you make a judgment. Say, oh, the sample shows, good language, so you are not using any official ways to analyze it. That will be an informal part of the assessment. Anything you might design your own testing instrument and use it, but it is not standardized, so it's an informal. So impressions that you make, for example, if you ask a patient to remember 3 words, and then ask them later, a half hour later, to tell you the 3 words, that is part of an informal assessment. So typically, an evaluation or an assessment includes formal measures and informal measures. And then, when you conclude your assessment, at the end of your assessment, now you have identified problems, difficulties that the patient has. And you want now to see if you give the patient certain techniques, like say a child cannot say the R sound. And then you want to see if the child is ready to begin working on the R sound. And then you say, okay, let's try some ways to make the sound. Go like this. Lift up your tongue. And lift it up really, really high. And curve it, make it go backwards. Now, try this a couple of times and then say, okay, now just bring your tongue down and be, for example, put it there normally. And then say ah, and the person says ah, and then continue saying ah. And then tell them, as you are saying ah, do not stop. When I go like this, you lift up your tongue while you are saying ah, lift up your tongue and curve it backwards, like I showed you before. So R. Once you do that, now you have facilitated the R sound. And then you can say, okay, now shape your lips, make them rounded or square, then R. If that works with the patient, immediately say, oh, the patient is stimulable, means ready. If I give the patient some stimuli, some tasks, some strategies, he or she can make the sound. And that obviously is going to give you indications about how to begin treatment, what to start with, and so on. And stimulability testing in voice disorders or voice testing is called probing. So typically we do it as part of speech sound disorder testing, and we call it stimulability testing to see if the patient or the person is ready, has the readiness to begin producing the sound when they are given strategies. And then prognosis. A prognosis is a predictive statement. A prognosis is excuse me, a judgment statement based on analysis of everything that you have, based on the scores, the case history, the medical history, everything that you get at the end, and say, okay, now, what are the possibilities of improvement? How likely is the patient to improve and, for example, improve skills in producing or achieving these skills, for example. So, evaluate not just what the patient is able to look at the stimulability. Given that the child is stimulable for producing these sounds, given the support of his family, given this and this and that, the child is expected to make good progress. So you can't because you cannot predict a lot of things that go on with the life of the patient. You can't predict how the family will be supporting, how the teachers will do their, follow up and so on. What you see, you protect yourself and make a statement that is well phrased, given, say given, blah, A, B, C, D, then, the patient is expected to make excellent progress or is expected to make good progress towards achieving these goals. And, but there are situations when it is not going to be easy. Like say someone has dementia. What is your prognosis? Dementia, basically, the patient is declining day by day. The decline is, keeps going. And what is the prognosis now? So in cases where it is not likely that the patient is going to make progress to reverse the problem or kind of to actually achieve typical functioning, or, that they are not expected to make significant progress, then that is called guarded. So guarded means progress is going to be very hard to make, and it will not be as, robust. So that is guarded. That's in severe cases. Like someone had a stroke and the stroke is massive and it's affecting a lot of the functions and, and so on. So, the progress could also be described as fair. If the person is kind of, it is fair. There's a possibility of progress. It will be decent, but, it's kind of not like the ideal situation that you would expect. Like with a child who is, say, who has a very supportive family, the teachers are on everything, and the child is motivated, and the child, for example, responds really well, and the stimulability is excellent, and all of this. And you say, if these conditions continue as they are, then prognosis is good, is really good. Or, it is fair, given this and this and that, the prognosis is fair. We are not excluding progress, but, kind of don't expect really like remarkable progress. But children typically, they develop so well in most cases, and they make excellent progress, especially when all the conditions are present that would facilitate that progress. When you report the results, reporting results involves writing a report, and we're going to speak a lot about this throughout the class, and also sharing the progress. Typically during a meeting, when you do an evaluation, you sit at the end with the patient, and then you have a copy of the report. They have a copy. Sometimes you might not even, like when you do a voice evaluation, you are not gonna have the time immediately to share the report with the patient, but you are gonna sit at the end and then say, okay, these are the findings, these are my conclusions, and for example, so you can make your consult with the patient immediately about the results of the testing and go from there. So as I explained, formal testing involves any kind of standardized test or criterion reference test. And we'll explain the differences. So a standardized test is a test that had been given or administered to a large number of, cases in the population, maybe 5,000, maybe 10,000, maybe 15, 20,000. The larger the sample is that took the test, the more accurate the test is. It's like flipping a coin. You could flip a coin two times, and chances are one time is going to be, heads, one time is going to be tails. So that is going to, so 50% chance. However, if you have the person do it 10 times, they might not get 50. There's a chance they might get 50%, but they might get maybe 7 times where it is all tails. So and then you do 1,000, then it becomes more accurate. So anyways, when a test is normed on a large population, it becomes more valid. It becomes, the data in it becomes more accurate. And these standardized tests come in with particular conditions to administer them, for example, in a quiet environment, to administer them doing this and this and that, and very clear where to start, where to end, and if you make any changes in the administration of these tests, the results will not be valid. So then, the test that we started to look at last week in class is a standardized test. And criterion reference tests, they are similar in the way that you administer them. However, they were not standardized on a population. Standardization takes a long time. It takes a lot of effort. But someone might go and look at, the text, for example, language acquisition and development test. A text. And then they will say, okay, children from 2 years of age to 8 years of age should have these skills. 1, 2, 3, 4, 5. They take all the language skills that a child is supposed to learn at a particular age and list them. And you say, okay, now I'm going to test, look at a child who is 8 years old. I'm going to see how the child is working, how his or her skills are. And then I compare the scores the child gets, the raw scores. I'm going to compare them to the norms that were given to us and saying, these are the skills that an 8-year-old child should have in terms of language. So I'm going to see if the child has all these skills or has less or something is missing. So that's the idea. But these tests are not administered to people like a large population or anything before they are used. Informal assessment, again, includes everything else other than standardized testing and other than criterion reference tests. Anything else that you do as part, that becomes part. If you design a certain task and you say, well, I'm going to see how this child is going to work, how the child is going to remember, say, sentences. And you just design a list of sentences, maybe 10 sentences, and have the child, repeat them to you after, and then you kind of estimate them. That becomes part of an informal assessment. Informal assessment, again, it is qualitative. It doesn't look for numbers. It looks at how. So it includes information that, for example, you get from case history, from the interviews you get, questionnaires, clinical observations, the audio and video taping, and an analysis of language samples. If you do the analysis by yourself, based on your own judgment, okay? So you have someone tell you a story, and you notice that consistently the child takes out the S, for example, the third person S, like she plays, he would say she play. He runs, he would say he run. And then, so you identify something, say there's a problem here, and you identify it. And then you look at the number of utterances, the number of say morphemes in an utterance, and you tally and calculate based on your own how you do it yourself. That is informal language sample analysis. Now, there are ways you could get the analysis and actually make it formal. You go to a manual that gives you like the mean length of utterances. It gives you exactly criteria that you use in order to count and to tally your sample, and then you come up with a particular score, a particular MLU, for example, based on criteria. So that is this is similar to a kind of criterion reference somehow. But so if you do it as formal, is that you are going to follow a particular protocol, you are going to follow, you go to a manual, you go to a chart, and then you get, say, for example, that particular equivalence or some kind of score that will show. So that the analysis, again, this applies to language sampling. So methods of assessment. First, you could do standardized assessment. You just go get a commercially available testing and you go and administer that. You could, in addition to some informal testing that you do, you could just administer a criterion referenced test battery in addition to other things that you do. Or you could do authentic assessment. An authentic assessment, there are different forms of it. The idea of it, as the term indicates, authentic means reflective of how the patient uses the skills in real life situations. Like you want to see how the person, say someone with a head injury comes to you, and you want to do the assessment to determine the effect of the problem the patient has on work. How does the person, the man, can interact at work? How will she or he, for example, perform their jobs and remember the duties and this and that? So authentic means, ideally, you go to their work and you go and take notes and evaluate and see how they are doing at work there. And what difficulties do they have, under what conditions and what circumstances? Or you could say, we can't take them to work yet, but we are going to simulate. So we'll structure the environment and make, put a desk here and put a phone there and this and that and simulate a work situation and say, okay, now I'd like you to do this and that and see them through the task. And then you are able to identify what is going on that is a strength and what is going on that is an area of weakness or area of need, as I like to call it. So that is authentic. You want to see performance in context of life, that in different aspects of life of the person. There are different forms of it. One is dynamic assessment. One is ethnographic. We did not address ethnographic. I doubt that any one of you is going to venture into it. The idea of authentic assessment is it needs a lot of skills. It needs flexibility. It needs expertise. You can't just go and, make something, some kind of assessment like this. And generally, health insurance companies would require some form of standardized assessment. They want scores. They want averages. And also, school systems, require some form of standardized testing. You do not have to do the whole evaluation based on standardized. Like I said, any evaluation should include both standardized and non-standardized, or both formal and informal methods, because the informal methods could be more revealing, as a matter of fact, than the standard, or could be equally effective as the standardized or as the criterion referenced measures. So for this reason, typically the majority of us rely on standardized testing in addition to other forms. So, I'm going to discuss first the non-standardized instruments, and then we'll spend more time speaking about standardized instruments. So criteria and reference tests, they focus on predetermined criteria. By the way, what is the singular form of criteria? Tell me next time we meet in the class. So they focus on the predetermined criteria that are based, there's an error here, that are based on developmental research. Like I mentioned, any language development text is going to have charts, it's going to give you milestones, by this age, say between 18 months and 24 months, a child should begin combining, words, single words. The child should start in their utterances to combine two words together, and they could go 2 to 4 words. So, and then definitely between 24 and 36, the child should be between 3 and 4 words in one, average utterance. So, the MLU is is going to be at this level or that level. These are the developmental kind of norms. The developmental, the data that research in language development has identified over the years. And then the criterion reference test takes these as 1, 2, 3, 4, 5, 6 skills that are required for this particular age. And then you have a test that asks questions about these skills, and then you administer it, and then you compare and see if the child is missing one of these skills or not. So, why are the criterion reference tests used? Basically, they are used more in situations when the standardized tests are not as good, or not as suited. And that is, I'm going to speak more about this later. But they are used for the purposes of planning, for the purposes of designing the content of the treatment, and for the purpose of redirecting treatment, for example, and for the purpose of determining the level of progress of that treatment. So they are not as rigid as standardized tests, but you administer them the same way. You do not give any clues or any hints. You follow particular rules. So they are used, typically when standardized tests are not effective as much, that is with neurological disorders and fluency disorders, for example, voice disorders. Because there's a large variability in the differences, for example, between one patient and another. And it's very hard to establish standards in these areas. Because if someone has a stroke, for example, that stroke is going to be very different than the stroke someone else is going to have. The place will be different. The severity of it will be different, and so on. So it is also used in some aspects of language and some aspects of articulation. One example is the language sample analysis, like that is based on, let's say, Brown's morphemes, the MLU that you derive, that is basically based on some kind of criteria that was preset, like that a child by 18 months or by 2 years of age, they should have utterances. The average utterance should have 2 words in it, for example. So that's an example. So also developmental language questionnaires and profiles. These are questionnaires you send to parents. Some of them are designed by companies. I'm going to make sure to bring one next week. Basically the SELF-5 questionnaire, that's at the end. That's the kind of criteria and And the SLP is a standardized test, but they provide this and they tell you that, they don't have standard norms for it, but they give you criteria so that you can compare the level of performance and have a rough estimate about the skills. So if you click on this link, you're going to find some aspects, some description of the SLP questionnaire, but I'm going to bring you a copy of the full questionnaire next week. So the idea of authentic assessment generally, authentic assessment, it's a non-traditional way because, some experts will say, well, the standardized test just has a limited number of, items. It doesn't cover all the areas. There is not one single test that is going to explore every single aspect of language, for example. And I'm using language as an example because it's a very, very wide domain. So they say, we'll get more information about the patient and the progress if we actually do some kind of authentic assessment where we test in context. I'm going to go to the classroom and I'm going to spend time observing the child when the child is completing reading, science, math tasks, and you name it, when the child is interacting in the cafeteria or doing this and that, or go home and observe the child. So you get, of course you get more, but you don't have scores that are objective. There's a lot of subjectivity based on opinion and judgment. And you and I, or have 4 or 5 people come and observe the same child. We see different things. We make different conclusions. Someone might not see any problem and the other person would see a problem. So there's a wide variability and based on judgment and so on. But the idea again is, keep this in mind all the time. It is a combination that will work best. It is a combination. So the focus here is on quality more than quantity, more than scores. You want to describe how is the person doing, in what situation, in what environment, and exactly study everything within the natural setting. You are able to kind of change things in the environment to help the person do better. You are able to give cues and you are able to explain things. In the standardized tests, they give you a couple of items before you start to practice and to ensure that the person understands how to respond. And after that, and you can give them cues here and there when you do the practice items, the demo items, but once you start testing, you cannot give any form of any cues by gesture, by facial expression, by nothing at all. So the idea here is they are conducted on a regular basis to evaluate progress and to also help with planning and with modifying treatment as you go. Treatment modification is required constantly because you should be making progress on an ongoing basis. And if you absolutely know that you cannot make progress with a patient, it is unethical to continue the treatment. So components of the authentic assessment, these are in your textbook, page 8. They include systematic observation, means that is also part of the regular, any kind of assessment. Throughout your evaluation, you are going to observe whatever the patient is doing, whatever the patient is saying, and how you interpret that in terms of how does that help you understand the performance of the client. And then real life situations, simulations, that is of course not, it is only unique to authentic assessment because you want them to demonstrate the skills within the natural setting, either at work or in school or at home and so on. And of course, you do not do this in the standardized. Language sampling is part of any assessment that you make, especially when we speak about language, I mean. So it is part of any assessment that you make. You have, give the person certain tasks, engage in a conversation and so on, and then have the person speak spontaneously. You want to know for sure the natural, how the patient is speaking in an average day, on an average task. Also, they do structured symbolic play. Symbolic play is pretend play. And they plan a situation. This structured symbolic play, you could do it, in many cases, you do it in order to get a language sample. So that is a way to organize the environment to make the person engaged, and especially children, and to, give them something pleasurable to enjoy working on, and then they speak naturally. Your idea is to get the most spontaneous and the most natural way of communication from the person. They involve getting short answers and then asking more about these answers to expand on them to get more information on them. You cannot do this in standardized tests. And then they also involve self-monitoring. The patient is able to watch herself or himself while they are being tested and say, now, this is a strategy that has worked for you. I need you to use it again, and so on. Self-assessment. How do you think you are doing? Could you do better? Again, you cannot do this in the standardized assessment, kind of. Use of anecdotal notes and checklists. You might have the patient take particular notes and then follow up on them. You might give them a checklist and say, okay, now, before you answer, I'd like you to look here and see what you should do first. You do a lot to facilitate accurate production. Audio and videotaping, you could do this also in any kind of assessment, and it is very important when you do it in voice, when you do it in social communication, in speech articulation, so fluency. Audio taping, video taping is very, very important. But you have to remember, you have to obtain a release form before you do this. You have to get a consent, and also to state in the consent what you will do with these tapes at the end of the evaluation or the end of the treatment. For example, give them to the parent or destroy them or what. And they also involve caregivers and other professionals. They could be present in the evaluation in different contexts, and they could give cues, they could help facilitate. But again, if you are doing a standardized assessment, you cannot have anyone, for example, give cues or whether visual or any kind of, otherwise the standardized assessment would not be valid anymore. So dynamic assessment is part of authentic assessment. The highlight of this kind of dynamic assessment or this kind of authentic assessment is that the primary goal is to identify, to understand how the person can make changes, how the person can give you better responses if you give them clues and if you teach them. So you ask a person, say, for example, I'll go back to the same example with the she play instead of she plays, he run instead of he runs. And so you say to him or her, that when you have he or she or it, you need to put add an S to the verb. And I'll give you some examples. The cat climbs climbs the tree. The dog jumps, and you give him or her, and then it walks or it falls. And you give them some examples and say, okay, now. And then you ask them other questions that have this, the S, and you expect them to add it, and then you see how they will do. So what you do is you test first. And when you do the testing first, you do not provide any clues. And then you provide the intervention. You provide the teaching, and you give the clues and all of this. And then you retest again after you complete your intervention. And then you compare the second, the results that you get from the retesting, compare them to the previous results. The previous results serve as baseline. That's the starting point. And then the retest scores are going to be compared to the baseline to determine if your instruction was effective in making the patient or the person perform better. And if that is the case, then most likely the person is not going to require a lengthy treatment, process. And you could do this in one session. You could do it in 1 week and so on. That is the same system that is used, the same system of assessment that is used in RTI. If you are not familiar with this already, you really, really will be. RTI is response to intervention. It's a program in the schools, and the purpose of it is to identify children who are kind of borderline, who do not qualify for disabilities, yet they need some strategies and some things to help them avoid falling into the disability category. So if you give them these strategies and so on, and they respond well, the school is going to design a 6-week or an 8-week program for them to have them use these strategies, teach them and give them focus more on the areas that they need kind of to fill the gap in. And after that, they retest and say, okay, is the child responding to the intervention we provided? And if the child has responded, then they do not, they determine they no longer have weaknesses, and then they leave the program and continue with everyone else. Or that they need services. They haven't made as enough improvement, and in that case, they would recommend that you go through a full evaluation, and then they could qualify for services after. So that is RTI, and it uses the same. So some of the purposes that authentic assessment is used, and there are tests that are sold called dynamic assessment or ethnographic assessment. They give you kind of the directions on how to do that and how to analyze and so on. But they're not used as frequently. So this dynamic assessment is used mostly, and it is most suited to cognitive communication disorders. For example, someone has dementia or a head injury that is causing language problems. And then you could do that. You want to basically ensure that they are responding well to you when you do the intervention. So the first thing to do is you test them, and right after the session, or maybe the week after, then you do your, look at the items that they didn't do well in, and they identify patterns of errors, and then say, okay, then the patient has difficulties in these areas. I'm going to provide intervention in that regard, and then go back and test again and see how much they benefit from that intervention. And if they show immediately that they benefit, then that is going to decrease the number of times that you see them, and they might not qualify even as having very serious disorder. You also could do it for people who are bilinguals, like they come from a different country and they are learning English, and the question is, for example, does the person have a language disorder, or does the person have a language difference? Language difference means that there are things in the native language of the person that make it hard for them to acquire the second language. For example, someone in his or her language, native language, doesn't have the O sound, or doesn't have the sound, like in Chinese, for example, So that kind of causes the person to have difficulty. Yes, it can be treated, but they could have difficulty basically making the because it's not part of their language. So there are many people who will put the L instead of right. It could be light. So one of the things is when you look at how like in Arabic, for example, the adjective comes after. The adjective comes after a word, after a noun. For example, like Casa Blanca, that's a Spanish. Casablanca, that's a Spanish. Spanish follows the same system like Arabic. So Casablanca, Casa means house, Blanca means white. So you say the house white means the white house. In English, of course, you have this. So if you have someone, say, from an Arabic country, Arab country, and they speak and they say the car red, and then you say, well, and then they speak, the book small, and then say, there's a language disorder here. You want to make sure to evaluate, to understand what the language background is, and have some knowledge of the system of language that they are speaking. And then if you know that in their native language, this is how their native language is, then you say, that is not a disorder, even though it is incorrect usage. But you say, well, that is because the person never had the experiences, didn't have enough experiences with English to make these corrections. But when we give them the experiences, like everyone else, then over time, they will develop the right usage. But what for now, this will be classified as a language difference, for example. So you do dynamic assessment. It is suited for culturally, linguistically diverse patients. We don't call them patients, of course, now, because that is not a disorder. And to differentiate if they have a true disorder or if they have a language or a cultural difference. The cultural difference is mostly, it incorporates more non-verbal aspects of the communication, for example, like how do you use your gestures, how do you use your body language, so that becomes part of the cultural component. So now we'll spend the rest of the remaining few minutes looking at standardized testing. So standardized testing, as I mentioned, it involves giving the test to a large number of the population to sample the population, and based on sample different ages, different gender, gender and the age, and also the cultural background. And the results typically shouldn't be very different. Like if you examine the English language of people in New England or people across the United States, you are going to find that they are going to basically use the language that is used on TVs and the government language, for example. The results, again, in terms of the setting, the environment, everyone shares here. They share a general kind of, form of language that we all recognize, that is used by the government, that is used by TV, for example, language and the media and the textbooks and so on. So the results shouldn't be different. For example, if you get these tests that are standardized on how people use the language in California, in Florida, in Texas, in Massachusetts, in different parts, and then anyone who takes that test is going to expected to perform like everyone else. So the group to which the test was given before it became available in the market, that is called the normative group. That is the group that sets the norm. Say, this is the thing, that the yardstick that I'm going to compare everything to, or everyone that I'm going to evaluate. I'm going to compare them to this group because that group represents a sample from all the population. Chances are, if I test everyone in the country, they will do the same way. So based on age, gender, and culture. A standardized test is going to give you scores that can be plotted on this curve. Have you seen a bell, like the Liberty Bell? See, this curve is shaped like a bell. We call it the bell curve. And it's going to show the normal distribution of performance in any population. Whenever you give any test, this is not speaking about one test, this is any particular test. It tells you, if you give a given test to a number of people, let's say 1,000, you are going to find that 50%, half of the population, is going to score in this area. That means if your test, given the test really reflects the sample, reflects the population in general. If you give this test to 1,000 or 1,000,000, half of them are going to achieve this score. Let's say the test uses a standard score of 100. So it means that here, at this mark here, that half of the population are going to score at 50%. That is called the mean. Then, if you go above to the right of the mean, there's a distance here. Say, here's 100. That's a standard score. I'm going to explain to you. And then between it and there's, you go 15 points on the right, to the right, and 15 points to the left. So the 15 points to the right are going to show you from the mean to the right, that is how a score is higher than 50%, I'm sorry, more people than the 50% of the population are going to do here. So between this line, the mean, and 115, it means you have now from here to here is called one standard deviation. So it means this side is called high average, or the higher average range part here, or range. If you go 50, this line here again, the mean, and go below it to the other side, 85, that is still called average. However, it is in the lower end of average. So the cutoff here between 85 and then 115, it makes what is known as the average, as the normal. And statistics show that when a test is designed accurately, 68% of the population, like if you test 1,000, 680 of these people are going to perform. They are going to get scores between 85 and 115. Okay? So then, when every step, when you move away from the mean, you're gonna move in this particular, test here, in this particular case, you're gonna move 15 steps. That is most of the standardized tests do that. For every kind of, you go to the right, you move 15 steps, and then 15, 15. So from 115 to 130, that is called now 2 standard deviations. Here's one and here's one. That is 2 standard deviations above the mean. 2 standard deviations above the mean here. The mean is usually 50% here. And then you go below to the left from the mean, this line in the middle, to go back, keep going to 70, which is 85 85 minus 15, that is 70. So that is 2 standard deviations below the mean, below 100. Sorry if I'm oversimplifying here, but I do not want to risk you not understanding this critical information. You should have studied it in your math courses and your statistics and all of this. So, but again, because you are going to base a lot of your work on, and the judgment you make and all of this based on the understanding these scores. So between, 2 standard deviations above the mean and two standard deviations below the mean, that is basically where 95% of the population who takes the test is going to perform. So out of your 1,000 cases that you gave this any particular test to, you should have 95% of 9,500 performing between 70, a score of 70, and a score of 130. Then you go one more standard deviation to the right. You are gonna go to 145, 130 plus 15, 130. So that is the top 2% of the population, like the top 2%. And you go another 2% below 70, then you get between 55 and 145. That is 98% of the population exists between. But again, only 2% below 70 to 55, 2% here of the population fall in this bracket. And then on the other end, 2% who really do well fall on that bracket. If you go one more standard deviation here, you have the very top 1% of the population. So we use these distances from the mean to make decisions about if someone is going to receive services and how frequently and how long and so on. You say, well, if someone falls between in the distance below 85, and for example, they would qualify for services in most states. Some places would say, well, they have to be 1.5 standard deviations. That means you subtract 7.5 from 85, the person will be performing here. That is very, very involved. That will be moderate to severe. So, then 70, for example, 70 is severe. It shows a severe problem. For example, IQ tests. If someone scores at 70, technically that is mental retardation, otherwise known today as intellectual disability at 70. So we do the same in language. Someone might perform, say here between 185, they will say, oh, average roughly. But if they go to 85, I simply say borderline, because that is the very low end of average. That is the beginning of the below average. And then 85, from 100 to 115, the upper end of average. And from that, it is called above average. And then you can call any that goes above here, you can call above average. Anything that goes below 85, you can call below average. But we tend to be more precise and classifying things as, like, say, above average, we can say superior, and different labels that different tests use, but based on how the standard deviations, what the standard deviations mean to them and what they want us to understand about them. So in addition to the standard deviations here, we need to also determine again if this, we to understand the curve in terms of average, below average, above average, and so on. And this is what you do when you evaluate. You constantly are going to look at these data. So the standardized score test is going to give you, for example, what is known as standardized tests. What you do is, remember the test that we started in class. You got a raw score initially. That's how many items you completed correctly out of all that was given to you after you reached a ceiling. Then you go to a manual, and that manual is going to give you a standard score. In statistics, they call it a Z-score. In speech-language pathology, we never, ever call it a Z-score in clinical practice. So it's a standard score. And then there are also stay-nines. A standard score is based on 100, at the mean of 100. And the stay-nine is based on the mean of 5. 5. So you go here, say stay-nine, and you go, the mean is 5. 5 equals 50%. It equals 50 percentile. It equals 100 standard score. So all of these basically mean the same. But instead of, let's say, the percentile, comparing the person to 100 people, for example. As an example. When you say percentile, let's say the person achieves at the 50th percentile. You say, well, the person is doing better than 50% of the population. So if you are giving that test to 100 people, say, oh, the person is doing better than 50 people. And if you speak about stay-nines, you say, oh, the person, I am comparing the performance to 10 people, and the person is doing better than 5 of them. And you notice that there's 9 here, that's 9 includes the distance between 9 and 10, but there is no 10 in that regard. And also the same for the percentile rank. You just reach 99th percentile and you don't have 100. Scaled score is another kind of score that you get, like standard score, but it's typically in language testing. It is a scale score. Typically is a 2-digit score. Like it can be 7, it can be 14. So a scale score of 7 here, 7 equals 5, a stay-nine of 5, and it equals normal curve of 50. It equals percentile rank of 50, and so and the standard score of 100. Again, the scaled score, 7 is the average and is the mean. And a standard deviation, when you do scaled score, a standard deviation is 3 points to the left or 3 points to the right. Every time you move 3 points, that is one standard deviation. At some point, we'll show you when you do look at the self-test, they use some scaled scores. So what is the difference between percentages and percentiles? Why do we never use percentages in our testing? Percentage would be based on how many items of the test were done correctly. See, focusing on items, and that we do not do that. But the focus of percentile, we say, if you divide the population into categories and you say, okay, there's 1/10 of the population and then another 10th of the, or 10% of the population are here. And then the 20% are here, 30%. So you are comparing to how many people in the population did, the person did better than when they took the test. And then language equivalence scores, standardized tests give you some kind of unofficial, or what they call them, some kind of scores that are not standardized scores exactly. For example, they tell you the age equivalent. When someone takes a test and they fall way below the first percentile. Or they might get, the first percentile maybe. But what does it tell you? It tells you a severe problem, but it doesn't explain it much. You want to explain it a little bit more. So they give you a chart where you say, okay, I'm going to get an age score. That means compared to the age, just simply compared to the age, how is this person doing? So the person you are testing is 9 years old, say with autism. So you go and say, compare the performance to the age, expectations based on the norms of, the research, and say, oh, he's 9, but he's actually performing on the level of a 2-year-old or on the level of a 3-year-old or a 4-year-old. So it gives you a rough estimate on where that would be, so you can explain to the parents. And again, we only report it when it is not possible to report or to have standard scores. Grade equivalent is the same way. You want to say, oh, you do, a language evaluation or a written language evaluation, and you want to see how does the person compare to the grade level, and they give you grades where you can take the raw score, convert it to a grade equivalent, and say, oh, he is performing on the level of a 4th grade or a 5th grade, and so on. Again, these are rarely used, but they're used in certain situations when the standard scores are not telling much. Limitations, again, they are estimated. They are could be misunderstood. They are not extremely really accurate in predicting the exact level. So like I said, we use them when standardized tests are too meaningless. Like someone getting 1%. But it doesn't tell us much, but in real terms, someone coming in with this level of skills, what will he or she compare to? So standardized tests have their own advantages and their own disadvantages. I do not need to go through them. You can go to your text to understand the differences. But again, they tend to be rigid. There is no perfect standardized test or test battery that covers everything and that covers everything in depth. So your ideal situation is to pick and choose different subtests or different parts from various tests that are made to score, to measure particular skills that you want to measure. And we'll speak more about this in class. The concepts of validity and reliability, these are things that the test is going to, mention in the manual. But we need to understand a little bit about these. Basically, validity means the extent to which a test measures the skills that it claims to test, or that it was designed to test. For example, this test is going to evaluate semantic language skills. And then I look at the items. Every single item of that test should focus on some type of semantic question. I should not find, like, for example, comprehension or tests, parts of the test that are not focused on. So all parts of the test must be focused on the skill that it claims to test. So there are different kinds of validity, and there is a content validity again, that the content should represent the domain. If I'm testing semantic skills, that the content should test every aspect of semantic skills, and every aspect is probed or assessed or measured by one or more items that pertain to semantics. Construct validity. So it is the degree to which a test measures the predetermined theoretical construct. For example, that needs expertise. It needs research. If we speak about language testing, for example, you get research that over the years showed us what level should everyone have at a particular age. What skills should we have at between 18 months and 2 years? What should we have between? So it gives you different levels, and based on that, the test should be consistent with the research, in other words. Criterion validity, that is, the test measures what it was designed to measure because it is correlated with an already existing variable that is valid. For example, there are two different kinds of validity: concurrent validity and predictive. Concurrent means that the test scores correlate with scores of another test that measures the same skill. So, for example, we have a test called the SELF-5 and the test called CASTLE-2. And you do an assessment with the child using this test. I do an assessment with the child using the other. And we both look at the scores. Both of us should show that the person has a disability or doesn't have a disability. So that is what concurrent means. There's a test, and concurrently there's another test also designed similar to it, and are they exactly testing, giving me the same results? And then predictive, basically predictive validity means how valid the test is in predicting the person's performance in a future situation. For example, you took the GREs to get, we require it for grad school. And the purpose of this is to predict your ability to complete tasks and to succeed and to perform in the grad school. So this is what it does in terms of validity. And all of these items, again, have to be explained in the test manual. And we basically trust if a company publishes a test, then it most likely it is valid and reliable, because they do a lot of testing and have to report this by law. Reliability means it's like your car. How reliable is your car? It means if you say reliable, it is either reliable or not reliable. Generally, one, yes or no. So yes means 1, no means 0. And then there's between 0.1, 0.2, 0.3 until 0.9. The closer is it to 0.9, the more reliable it is. So it means if your car, say my car is 0.9, it means every time you insert the key in the ignition, the car will, and turn, the car will start. And if it is not reliable, you don't know. It depends on the temperament that the car in. Maybe it depends on your luck. So reliability is consistency. Like if you yourself give the test today, you get this kind of result, and then you do it again tomorrow, or you do it in 6 months, you should get exactly the same kind of level. Given that there is no intervention, of course. But so it means if you use the test with the same person, you are going to get the same results. And also, if another person tests the the person, the patient with the same test that you used, they should also get the same results. And there are names for these. But generally, reliability is reported again in correlation coefficients, means up to 0.9 or 0.990 means kind of the next one would be 0.1. I'm sorry, 1, just 1.0. Like this means yes, means it is reliable. But anything in between, it comes closer to in between yes or no. So to ensure that reliability, that the test is reliable, first you want to understand the test administration process. That is, also you read the manual before you understand the test. And you need to record your observational data that you collect. You need to be mindful of normal variability that between patient and patient, or between one person and another. There's a little bit of a margin where there's some kind of, little variability in performance. And also you cannot provide any cues or any hints of any sort to the patient, even with your hand. As if you do check, 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 and then circle, then the patient or the child is going to know that when you check, check means yes, I'm doing well. And when you circle, then you are not doing well. Then they will ask you, oh, I didn't do this right, huh? I need to think about it again, and so on. And you need to get something authentic in terms of spontaneous responses. So rate of reliability, again, it depends on you. What if you yourself test the person and retest the person? You should get the same results. And here, this is my emphasis, so that you differentiate between intra and inter reliability. So, okay, this is not how you write it. It is, again, for me to highlight this so that you know the difference between these two. Inter-judge or inter-rater reliability has to do with if two people or more administer the same test, will they get the same result? And there's alternate form reliability. Basically, many tests would have a form A and a form B. The test that we used in class last time is form A. And there's another form B like it. And both of them, if you give both of them to the same person, they should get basically similar scores. Split half reliability, it means that half of one half of the test, basically if you administer one half of the test, it's going to give you a similar score to the other half. And they do it by administering, say, the odd number questions, and then getting a score, and then administering the even numbered questions, and they get a score, and then compare. Did the person get a similar score in that regard? If that is the case, then you would have split half reliability. When do we not use standardized tests? We basically, in any case, when the standardized test sample does not include the population of the person that you are testing. Like, say, someone coming from overseas and they haven't, stayed here for more than 2 months. You can't give them a standardized test and report. You might if you want, but you cannot report the scores and say they have this, are performing at the 40th percentile or this and that. You can't, because when the test was standardized here, it was not standardized on people who do not speak English or who have not stayed in America, for example, all their lives, so that they would know the language. Another example is if someone has a severe disability like head injury or autism, for example, and they cannot comprehend the standardized testing, and the population on which this test that you are using didn't include a significant number of people with autism or head injury, then the test would not be valid in that case. So what you do is you look for alternative assessments. Let me see. I'm just concerned the video is getting long. Yeah, I'm almost done. That I would recommend that you interrupt it every half hour and take notes and so on. So basic considerations for doing testing, ethical matters. First, you need to make sure to read and understand the ASHA Code of Ethics, and we did that last week. What do we need to do to ensure that, for example, you follow the Code of Ethics with regards to standardized testing? This, you need to read go back again and take notes and look at anything that applies to testing, and you need to really make it part of your policy. First, we need to know the skills. You can't just go and evaluate in an area that you do not understand how the test works and how, that you don't have the expertise. And for this reason, actually, when you want, when you go and try to buy a test today from Pearson, they are gonna make sure to verify that you are a licensed SLP, that you have the expertise, and if you aren't, they will not sell you the test. And see, a company wants to sell, but it is so serious that they do not do this unless you prove that you are a qualified and licensed professional. So, how about people who have accents as a student clinician, or a student in speech language pathology, or a foreign, or someone like myself, or someone who is, any clinician has a foreign accent? I need you to go here and click and read ASHA's policy on foreign accents of, people who are non-native speakers of English. This will be part of the quiz, so make sure to read it. It's not long. It's only a half a page. We need to be objective in interpreting the scores, in reporting the scores. We should avoid as our personal biases all the time. We'll just be aware that what you do is your job is to honestly report the scores and interpret them based on the test measures and based on what the test manual says, and make decisions that are appropriately based on the actual test results that you get. Also, we are mandated to act on the best interest of the patient or the client, especially when we make recommendations. We cannot just make less recommendations than needed so that the school or the institution will, can save money and stuff like that. We have to put the client's best interest in mind when we make recommendations, when anything that we do, when we evaluate or give treatment. Also, we need to make sure that any scores that we report, they are accurate, and we obtain them accurately and report them accurately, and that we understand them and explain them accurately. When you administer a test, we are going to speak about this in class, but typically when you administer a test, you kind of seat the patient on your left. Usually have like a corner table, and you sit at a location, and then you have the patient on your left. And then you turn or ask the patient to turn a page, and then you write down and score. You need to give kind of a few minutes warming up to establish rapport with the client before, because your goal is to get the most spontaneous responses that are possible without pretense or without preparation or anything on the part of the client. If someone is tense or anxious, or, they feel they're being tested and so on, they might withhold. They might, show a better, a different side than what they are showing normally. How to determine the starting point. We explained last time how the test protocol is going to have a particular agency start here. And when you start there, you keep going and establish a basal. And once you keep going, and then once the patient doesn't respond to a certain number of items, you establish a ceiling. And ceilings and basals depend on any individual score. There's no universal, ceiling or no universal basal. Is determined by the test developer. We'll speak about administering the demo items. Some tests have them, some tests do not. What they say to you, administer all, or go ahead and have the persons do that. And if they do not do well, give them this cue or that, or ask them that question. And if they cannot understand the demo items, you discontinue the test. You cannot administer it, because you administer a test only if the person understands the directions and the questions, and they can actually do the test. Continuously are going to do clinical observations. From the beginning, you see the patient to the very, very end. And that is a very valuable record. Make extensive notes. And like I said, in some cases, if you choose to kind of check, the person on the other side is going to look and they get, cues, and they will, if they feel they are doing well, they are motivated, yes. But if they know that you made a circle, their motivation decreases, and they start asking questions. And if you give cues, then it, of course, makes the results invalid. In addition, it will make the testing situation very hard to continue. So, in that case, you circle everything. Circle whether there are two areas like yes, no, or 1, 0, and so on. You just circle this 1 or circle 0. And in the end, you calculate it the same way. And then where to stop? We said you reach the ceiling, and then this is where you stop and calculate your raw score. And from there, you go to the manuals. So here are many resources here, and some of them are online, and I'm going to add the rest of these also to the resource folder on Blackboard. So again, I would advise that you study your notes from this. And I kind of repeated a lot of stuff that we said in class, and also a lot of the stuff in the textbook. And in addition to my explanations, I hope you found it helpful. So we'll see you in class. Bye.